Okay, we're all back from coffee, and thanks for visiting our sponsors down in the exhibition room. We've got all our panel back, we've got all our teams back, so we're ready to start the second session. However, before we start, I want to give you the intermediate team results. Can we have the intermediate team results up on the screen, please? So we have on 921 points, we have Team Europe. On 876, we have Team Asia. And 783, we've got the Americas. I must really congratulate David Waller on how he's managed to give Team Europe 10 out of 10 for every question and getting his team up ahead. Steve Cassidy is not quite as good at it. He's a little bit less subtle, or more subtle, shall I say, than David. Okay, so that's our team results. That gives you a challenge for the last two topics. Can we now move on to our next topic, please? Could we have the slides, please, for our next topic, which is going to be infectious diseases. Right. So our expert for the infectious disease is Dr. Arvind Kumar, and I'd ask him to come in and just give us an introduction to this topic. Arvind.
Thank you very much. Good morning. Okay, so as far as development of thoracic surgery is concerned, tuberculosis and attempts at its surgical treatment were actually the beginning of the art and craft of thoracic surgery. However, with the development of anti-tubercular treatment in late 40s and early 50s, this decreased because medical management was the order of the day. Malignancies and trauma, at least in the developed world, for the next 50 years constituted most of thoracic work, although in developing countries, tuberculosis continued to be a problem. However, now there is a resurgence in the incidence of infectious diseases, courtesy MDR and XDR tuberculosis, and a steep rise in fungal infections because of various reasons. So when we look at the etiology, it's a wide group, thoracic infectious diseases. We can have bacterial, tubercular, mycotic, and parasitic, and they could involve lungs, pleura, mediastinum, chest wall, or the tracheobronchial tree. In the bacterial, you have the usual pneumonias, lung abscess infections. In the pleura, you have empyema, mediastinum, mediastinitis, and chest wall infections. I'll just show you a picture of a chest wall infection in a patient that occurred following an ICD, intercostal drainage infection. This is patient's left side. What you see there is the axilla and the left arm and the whole chest, how the whole chest has necrotizing infections. These things, unfortunately, continue to occur. Most important is here the tubercular infection, which could be in the lungs in the form of infiltrates, abscess, fibrocavitary disease, bronchiectasis, or the destroyed lung. Pleura, it could start as tubercular effusion, turn into empyema, go through stage 1, 2, 3, ultimately end up with what is called fibrothorax, where the whole chest is tight. You could have tracheal or bronchial strictures, you could have necrotic mediastinal nodes, even turning into an abscess, and it could come out of chest wall as empyema necessitans. There is an increase in mycotic infections, whether it's aspergillus, mucor, histoplasma, crypto, coccidio, or candidiasis, and any of these could involve any of the organs which are there in the chest. In addition, we also still see various parasitic infections, which could be because of various protozoa and helminths. The common ones being hydatid disease and pleuropulmonary amoebiasis, although dirophilariasis and pulmonary paragonimiasis also continue to occur. So let's look at the cases now, and then we'll come back. Thank you.
Thank you very much, Arvind. So over to the cases. And the subtopic for this one is the parasitic lung diseases. The first scenarios are going to be presented by Team Americas. Over to you.
Good morning. Here we have a 45-year-old male with no previous health problems. Presented with high-grade fever with chills lasting over the past 15 days and abdominal pain. He also had cough with cough ground spurt, and 2 consecutive spurt samples revealed entamoeba histolytica trophozoites. Here you can see the CT scan showing right liver abscess with adjacent lung abscess. And the question goes to Team Europe. Which of the following is correct about the treatment of the condition? Number one, clinical treatment with anti-amoeboic drugs is effective in most cases of hepatopulmonary amoeboids. Despite the use of adequate medical treatment, the lung resection of the amoeboic lung abscess is essential to prevent the recurrence. Surgery must be performed as an emergency procedure because the amoeboic drugs are ineffective. The combination percutaneous drainage of the lung and liver abscess with daily irrigation with metronidazole is preferable, minimal invasive treatment for the cases. And number 5, in case of pleural involvement with development of amoeboic pleural empyema, thoracic drainage is contraindicated due to the risk of hematogenic dissemination of the parasite.
Okay, righto, that's your 30 seconds starting now for Team Europe to come up with their answer. Not so many parasitic infections in Europe. You're going to have to rely on some of those who've got some more experience than you have. Put the UK candidate at disadvantage. So you now have just over 10 seconds left. Now, come up with your answer. So that's it now. Time is up now. Let's have your answer, please, Team Europe.
So we agreed that the correct answer must be answer 4, because in contrast to, for example, infections by hyotids, amoebic infections don't require extensive surgery as it is known. So a combination of minimal invasive procedures, such as a percutaneous drainage and of the lung abscess and the liver abscess, as well as the antibiotic treatment with metronidazole is the preferable treatment. And with this treatment, the chance of a recurrence is really low.
So the answer from Team Europe is?
Yeah, number 4.
Number 4, we're all clear, you got that? Okay, so we'll now move on to the second part of the scenario, please.
After 3 days of clinical treatment, the patient had worsening of the symptoms with pain, cough, and dyspnea. New radiologic examinations were performed. X-ray and CT scan showed evolution with pleural effusion. And now the question for Team Asia. Which of the following is correct about the case evolution? Number 1, the criteria to decision between initial VATS and thoracic drainage must be similar to those used for bacterial pleural empyema. Number 2, thoracic drainage is contraindicated due to the risk of hematogenic dissemination of the parasites. Number 3, the cortication is contraindicated due to the risk of hematogenic dissemination of the parasites. Number 4, due to this evolution, it is paramount to indicate emergency surgery to decorticate and perform anatomical resection, lobectomy, of the amoebic lung abscess. Number 5, due to its evolution, it is paramount to perform emergency surgery to remove the liver abscess in order to control the disease.
Okay, 30 seconds starts now. Start to formulate your answer. Asia will probably have a little bit more experience of this than the Europeans. Got to get the diagnosis right to come up with the right management. 10 seconds to go. Let's have the answer, please, from Team Asia.
So we have to preserve the lung capacity as much as we can, but since the evolution is this massive, we have to resect the infected lobe with a lobectomy and from the amoebic lung abscess.
So your answer is number?
4.
Answer's number 4. Got that clear? Okay. So now we're going to hand over to our expert panel, and they're going to score the scenario. For those who recently arrived, The panel will score the scenario, the quality of the scenario, and then the quality of the discussion of the answers from each of the teams. Now, when they're judging the scenario, speakers be aware, they'll be judging how clear you are and how quickly or otherwise you flick through the slides and how you go through the images in particular. If you flick through the images too quickly and no one can see them, and particularly if the panel can't understand the images, then you're going to be in trouble. So just imagine you're presenting them to a case to the panel, because you've got to convince them that your scenario is the best. So over to Frank now. Your score is a 9. There's a 10. There's a 10 from Julia. Arvind is giving 8. 8 from Walter. The 7 from Alessandro. David's got 7. Keith has got 7. Dr. Chida has 7, and 9 from Ricardo, and 8 from Steve. Okay. Now we want you to score the answer as given by the Europeans to the first question. There's an 8, there's a 10, a 7, Arvind's got 4, 8, David's making up his mind, or Alessandro rather, it's an 8 and it's a 9, 6, 7, Ricardo is 8 and Steve is 8. So we have those answers. Okay. So, and we have one more answer to score. That's Asia's answer to the second question. Frank's giving a 5. There's a 6. Julia's gone higher at 8. 5, 7, 7. Oh, David's making up his mind. Is he going high? Is he going low? He's gone low. He's gone 6 is low for David. 9, a 6, a 7, and very middle of the road, 7 from Steve Cassivi. So there's the answers from our panel. We're moving on to the next section, which is tuberculous thoracic infections, and I'd ask Team Asia to come up and present their scenario.
Thank you. So there's a 28-year-old female patient with no known comorbidity history, was diagnosed with pulmonary tuberculosis in November 2016. On rapid testing with Lyme-Prop assay to assessment of the drug resistance to both azithromycin and rifampicin was detected, and later on she was started on multi-drug therapy, including bedaquiline. Patient later achieved sputum conversion, turned negative at 3 weeks of bedaquiline therapy. Now she has persistent cough, but her hemoptysis hasn't reoccurred. The chest X-ray and the CT scan showed disruption in some bronchiectasis in the right upper lobe and destroying upper lobe. So my first question is to Team Americas. What should be her next management of choice? Continuing bedaquiline-based therapy for another 5 weeks and then later on consider her for surgery. Consider her for surgery upfront, and since she has achieved sputum conversion. And 3, as there has been no significant hemoptysis, consider for continuation of bedaquiline-based medical therapy. And 4, continue bedaquiline-based medical therapy and perform radiological guided prophylactic bronchial artery embolization.
Thank you very much. That's your 30 seconds starts now. And the audience, your 30 seconds as well. I'm sure there's some in the audience know an awful lot more about these diseases than I do. So we'll see what the teams come up with and see if they can confuse the panel with their results, their answers. Just over 10 seconds to go. It looks like they've come up with an answer, so the time is nearly up, and it is up now. So, Team Americas, could we have your answer, please?
Well, after we argue here, we answered the number 1. Is a lady of 28 years. She has MDR TB, and despite of the conversion, she will still have cavitary lesions, and she will have a great probability to recurrence of the disease. So we continue with the treatment for more 5 weeks and consider she for surgery after that.
So you're going for answer number one.
Yeah.
Okay, so we'll see if that's the correct answer later on. Do you want to carry on with the scenario, please?
So the multidisciplinary team discussed this case and decided to offer her surgery, and she was taken for surgery at 4 weeks on completion of betaquilin-based therapy. Her sputum status was negative before surgery. Her pulmonary function test results was FEV1 is 100%, and the predicted postoperative FEV1 value was 47% for pneumonectomy and 84% for right upper lobectomy. And during the procedure, intraoperatively, she had multiple nodules discovered in the right middle and lower lobes. So the other question is to Team Europe. What surgery should be performed in this situation? First, pneumonectomy. 2, right upper lobectomy as planned. 3, surgery should be abandoned at this time. 4, right upper lobectomy with wedge resections of nodules in the right, middle, and lower lobes.
Okay, formulate your answer. You've got 30 seconds. 4 options there. Some radical, some rather conservative. Which one are you going for? Should we give up altogether? Should the surgery be abandoned? Should it be a pneumonectomy in a patient with those lung functions? 15 seconds. Time is nearly up. Okay, time's up. Time for Team Europe to give us their answer, please.
So our answer is number 4. For us, number 1, a pneumonectomy doesn't really fall into, or isn't really an option in such a young patient, especially when she just has a few nodules, which we rather do a histological sampling of, and this can be done by wedge resection. Right upper lobectomy doesn't offer the histological assurance that these nodules have, or of the dignity of these nodules. And surgery should not be abandoned just because of a few nodules being detected during surgery. So number 4 is our definitive answer.
Okay, number 4. We'll see if that's right later on. So, thank you very much, Team Asia. We'll now ask for our panel to give us their scores for the quality of the scenario from Team Asia, starting with Frank. Frank's come up with a 9. There's a 10, an 8, a 10 from Arvind, a 9 from Walter, a 7, there's a 10, there's a 9 from Ricardo, and finishing with an 8. So there's our scores for the scenario. Next one are the scores for America's answer to the first question. Frank, there's a 6, a 10, there's a 9, a 4. Walter's gone for an 8. Alessandro's an 8. David's making up his mind. He's got a 6. There's a 5 from Akif. There's a 7 from Masayuki. There's number 9 there, and there's an 8. So one more score to come here from about Europe's answer to question 2. Frank's got a 7, a 10, 7, a 7, an 8 from Walter. There's an 8 from Alessandro, 8 from David, 7, 7, 8, and 10. So that's the final voting from the panel for scenario on the TB. So we're now on to other thoracic infections, and I'd ask Team Europe to come up and present their scenario, please.
Thank you very much. So the next case is about a 22-year-old male patient with a rare condition, a congenital hyper-IgE syndrome. And he has been suffering from repeated pneumonias with consequent putrid lung abscesses, resulting in multiple pulmonary cavities, predominantly localized in the left upper lobe. He was urgently referred to the hospital with a recent onset of minor hemoptysis, cough, and chest pain. Upon admission and examination, he reported no recent weight loss and no fever, and the serum-based galactomannan test was positive. A CT scan was performed, And we do have a video of the CT scan. You have to click here. And we also do have the sagittal and coronals of said CT scan. So our question to Team Asia is, what is the appropriate concept in this case? 1, treatment with liposomal amphotericin B, isavuconazole, and clindamycin. 2, bronchial artery embolization, substitution of human immune globulin, and treatment with amphotericin B followed by itraconazole. 3, thoracoscopic cavernostomy and treatment with amphotericin B followed by isavuconazole and Tazobac. 4, open lobectomy of the left upper lobe and treatment with clindamycin, levofloxacin, and amphotericin B, followed by voriconazole and IVIG. And 5, thoracoscopic cavernostomy and treatment with voriconazole, Tazobac, and IVIG.
Okay, so your time starts now. Which option are you going for? Where it says substitution there of the IVIG, that means an infusion of it. You'll see it's better put in the last couple of options. Your time is running out and it is now finished. So I want Asia to come up with their answer, please.
The option that we would like to go for is thoracoscopic cavernostomy and treatment with amphotericin B, followed by isavuconazole and piperacillin tazobactam. The reason why we're going for this option is because A, the patient bronchial artery embolization is a temporizing measure during massive hemoptysis and just a stopover for surgery. So option B is totally incorrect. Patient has been significantly symptomatic and has also had 1 episode of hemoptysis. So just medical therapy will not suffice. So that is why option 1 should also not be considered. As far as option number 4 goes, open left upper lobectomy and treatment with clindamycin, levofloxacin, amphotericin B, followed by voriconazole and infusion of 10% IVIG. We think that that may not be a very good option in this patient because he has nodules and cystic changes in both lower lobes as well, both the right as well as the left. And the 5th option also, we do not see evidence for 10% IVIG, and hence we'll go for option number 3.
So final answer number 3. So we move on to the next section of the scenario, please.
This is a question to Team America. Regarding non-resectional treatment, which of the following is not true? 1, relapse can be caused by failure to close all bronchial air leaks after cavernostomy. 2, relapse can be caused by disuse atrophy of the myoplasty flap. 3, a limited thoracoplasty aids in the reduction of the cavity volume. 4, myoplasty is not a significant factor in treatment success. And 5, cavernostomy is an appropriate treatment for massive hemoptysis.
Okay, your 30 seconds has started already, so you better start getting your answers in. Is myoplasty important? Is thoracoplasty important? Is cavernostomy enough? What causes relapse? Maybe you don't see this too much in the Americas. Maybe some parts of the Americas you do. We've got an expert on the American team who can give us the right answer. 5 seconds to go. So, Team Americas, your answer, please.
Our answer is number 5. We think cavernostomy is not appropriate treatment for massive hemoptysis. We have to resect the lesions. And the other answers we think are right because myoplasty and thoracoplasty are important things to collapse the other cavities that could perpetuate the disease. And the number 1 is right too, because we have to close all the bronchial fistulas to not perpetuate the problem.
So you have given us answer number 5, is that correct? Okay. So we'll see what the correct answer is soon. But first of all, thanks very much. And we're going to get the scores from the panel for the scenario as presented by Europe. At 9, a 10, a 10, they're high scores coming in here. There's an 8 from Arvind, 10, 10, 10 from David, 8, 7 from Dr. Cheetah, an 8 and an 8. So now we move on to the first answer from Team Asia. A 9, a 9, a 9, universal 9s along here. 9 from Dr. Veda, 8, 8. We're going up to 10s and 10s, a 9 and a 10. High scores all the way through there, so well done. Now, Team America's answer to the second question. What's Frank going to give? 8, 9, 8, 5. Now that's a drop. 9, 8, 5 from David. He's being rather hard there. A 6, an 8, a 9 and a 9. Tactical voting coming in here from the Americans. No doubt about it. Right. So we now call on our experts. Arvind, who was rather harsh on that last answer, so maybe you can explain that.
Thank you. So for the first question, the answer is number 1. Treatment with metronidazole is the treatment of choice, and it helps in controlling the disease in majority of the cases. The answer number 2 is not correct because the lung resection is not needed initially. The surgery must be performed. If you look at number 3, it says emergency procedure because the anti-amoebic drugs are ineffective. The fact is the anti-amoebic drugs are most effective. There is no role of irrigation of the cavity with metronidazole. It does not have any local action. Therefore, answer number 4 is not right. And in the case of pleural involvement with development of amoebic pleural, thoracic drainage is contraindicated because of the hematogenous. It's not true. So the answer is number 1. Moving on to, and that's the reference. Moving on to the number 2, the criteria to decision between initial VATS or thoracic drainage must be similar to those used for bacterial. It has to be, when the abscess ruptures into the thoracic cavity, it has to be treated like empyema. You have to put a tube, you have to drain it. Along with that, you have to give the anti-amoebics. Thoracic drainage contraindicated due to the risk of hematogenous dissemination? No, there is no such risk of dissemination. It's contraindicated due to the risk of again the same. Due to this evolution, it is paramount to indicate emergency surgery. There is no role of emergency surgery when the abscess ruptures in the chest. You first have to provide a drainage, you have to give antibiotics and anti-amoebics. Same way for the liver abscess also, most of the times it's the anti-amoebic treatment which works. And that's again the reference. For the tubercular infection, what should be her next management? There is enough evidence now that in MDR cases, if it's a localized disease, as I would discuss in the take-home message, once the patient has become serum negative, sputum negative, surgery offers the best chance of cure, provided the patient is a fit enough candidate. Continuing the bedaquiline is not the best of option. And that's the reference there. Next question, what surgery should be performed? No, pneumonectomy, no. Right upper lobectomy, if you do, you will leave behind the nodules. There's no question of abandoning, and therefore, right upper lobectomy, removing the nodules also is the correct answer. And that's again, WHO Europe Center had just come out with these guidelines recently. They're not actually guidelines. They have used the word guidelines, but then they have said that these are just recommendations based on the available evidence. Other thoracic infections, what is the appropriate therapeutic concept? So this patient will have an open lobectomy. Actually, he did have an open lobectomy and treatment with clindamycin because many of them have methicillin-resistant staph and levofloxacin followed by amphotericin and IVIG because the patient has IgE disorder. Thoracoscopic cavernostomy is only indicated if the patient is a very, very poor risk candidate, which this patient was not. And this is the procedure which was done, and this was the aspergilloma which was resected. Regarding non-resectional treatment, which of the following is not true? Relapse can be caused by failures is true. Relapse can be caused by disuse atrophy is true. Limited thoracoscopy aids is true. myoplasty is a significant factor in the treatment success. So not a significant factor is actually not true, and therefore this is the correct answer in this patient. Again, this is the reference. Now we'll go for the voting results.
Okay, so can we put the questions up? Right, so for the first question, quite a mixed bag of answers there, spread across the audience. This is looking like it's a fairly clear winner for question number 4, which was not the correct answer. Number 1 was the correct answer. We go along to the next question. Again, a mixed bag, and the correct answer only came in number 3 there. Next question. So clearer here, but there's a division between an upper lobectomy and adding in the wedges for the lower lobe. I'm not sure what those who answered answer 2 were going to do about the wedges in the lower lobe, or the nodules in the lower lobe. So the correct answer, number 4. Next question. And here again, a fairly clear answer for number 4 there. And fairly clear answer for, well, the audience went for number 5, even though the second answer there, the second most common was myoplasty, and agreed with our experts, the answer being number 4. Okay. So now we're going to move on. I'll hand over to Enrico for the thoracic infectious diseases. Okay. Oh, sorry. Let you go first.
Okay, now the take-home message, I'll just take up all the 3 diseases one by one. For the pleuropulmonary amoebiasis, it's caused by Entamoeba histolytica. Majority of thoracic complications result from extension of a liver abscess through the diaphragm. 2 scenarios can occur. In cases where pleural symphysis precedes the transdiaphragmatic rupture of liver abscess, so the lung is fused to diaphragm, so the abscess ruptures directly into the basal or other segments of the lung, leading to lung abscess. Treatment is similar to that of any other lung abscess, consists of postural drainage, antibiotics, but most important is specific anti-amoebic drug therapy. Now, cases where there are no adhesions between the lung and the diaphragm, the liver abscess ruptures into the pleura, as well as it can rupture into the bronchi, and these cases need to be treated like an empyema with intercostal drainage, strong suction, and you have to try and achieve re-expansion of the lung, and of course antibiotics and anti-amoebic therapy. In the anti-amoebic therapy, metronidazole is the cornerstone of treatment, but it has to be given oral or intravenous. There is no role of local application of metronidazole. And the indications for surgical therapy is a failure of medical and conservative treatment, persistent bronchobiliary fistula, post-infective severe bronchiectasis and sequelae, and presence and development of collapsed lung, and therefore a decortication will have to be done. Coming to tubercular infections, this is something which we see quite commonly in our country, and I'll just take you through a couple of photographs. So this is one of the lobes which was destroyed, bronchiectatic, post-tubercular. This is a post-tubercular destroyed lung. Again, another one where the whole thing has turned into a fibrous blob with shift of the mediastinum. This is how the specimen looks when you resect it. This is a fibrocavitary disease on the right side, destroying the whole of upper lobe. There is also disease present on the opposite side. This is a tubercular lung abscess, which these are all our pictures, our patient's pictures. Here the lung abscess has increased to involve the whole of lobe, almost presenting as consolidation of the whole lobe. This is a pleural effusion on the right side. This effusion can sometimes become multiseptate and go to stage 2 or even stage 3 empyema. And most of the time the lung is collapsed. You can see here when it causes fibrosis, if you compare the size of the chest on the right and the left side, you will find that the left side chest is now collapsing. So this is what we call fibrothorax. As the pleura contracts, the chest becomes smaller in size. You have rib crowding, and this is what ultimately leads to development of fibrothorax with severe compromise of the lung function on this side. When we decorticate these patients, the pleura is leathery, thick. Sometimes it's up to 2 to 3 centimeter in thickness. It's hard, and many times it's calcified also, and it's a challenge to remove this pleura. But removal of this pleura helps these patients. Sometimes the empyema ruptures through one of the intercostal spaces and comes into the subcutaneous tissue, what is known as empyema necessitans. These are necrotic nodes. This is something we see very often. Sometimes these nodes enlarge to big size, and they can even form a big abscess in the mediastinum, which sometimes needs a drainage because the patients are very toxic and have high fever. Many times it involves the bronchial tree. So this is a case where right tree is normal, but the left main bronchus is completely blocked because of the tubercular sequelae in the involvement of left main bronchus. Here, the left main bronchus is okay, but the right main bronchus has got involved. And here, it's the trachea which has got involved. So there is a myriad presentation that this disease has in various areas. And unfortunately, there is a resurgence in incidence of this disease all over the world, although it continues to be a major problem in developing world. So this is the recent meta-analysis. This was an individual patient data meta-analysis where instead of the pooled data from various studies, the individual data was taken. And also this is the WHO report from the Europe region of WHO that I referred to. Based on these, there has been an increased interest in the role of surgery in tuberculosis, particularly with the development of MDR, increasing interest. Also in the sensitive variety and also in the MDR. Medical treatment for MDR is complex and sometimes associated with poor outcomes. So there has been a thinking that surgical lung resection may be used as an adjunct to medical therapy to reduce bacterial burden and improve cure rates. So when is it indicated? Whenever there is a high probability of failure of medical therapy in the sensitive TB or more so in the MDR TB in the form of when at the end of the treatment you have a cavitary disease still present. It is thought that although these patients may be sputum negative, but when you do cultures from the wall of these cavities, many a times they still continue to harbor the bacteria. And therefore, if you leave this patient untreated after completion of medical therapy, there is a high chance of recurrence. Same way, if there is a lobar destruction or a lung destruction or a massive hemoptysis or a tension pneumothorax, these are indications where surgical intervention may have. Persistent positivity or progression of TB despite therapy. But the catch is that the lesion should be localized, it should be amenable to resection, and this patient should otherwise have a high risk of relapse. So if you have a lesion which has a high risk of relapse in a patient who is a reasonable surgical candidate in a disease which is localized, this is the ideal situation where probably intervention of surgery will help in reducing the possibility of recurrence. But it has been seen that best results come when you do partial lung resection. Whenever you have to resort to pneumonectomy, these patients do not do well. So a partial lung resection, and also the better results are there after sputum conversion than if you are forced to operate with sputum spill being positive. So sputum converted, patient in good health, needing partial dissection is probably the best scenario where surgery is going to help these patients, and these are associated with improved outcomes. So when would you consider surgery? When there is a persistence of the disease or there is a high chance of relapse of the disease is sufficiently localized, the patient is a good surgical candidate, and you can resect the disease. So this fortunately offers a window of opportunity for us to help out in the management of these cases. When would you not operate? If there is extensive cavitary lesions in the both lungs, impaired pulmonary function test, heart involvement, body mass index low, severe comorbidities which are present, and most importantly, when there is active bronchial tuberculosis present, because when you cut the bronchial margin, there will be very high chance of bronchopleural fistula. So this is a situation where you would not operate on these patients. Second last, fungal infections. So this is how aspergilloma looks like. I'm very fond of showing this picture to my pulmonology friends and ask them which amphotericin B is going to make this mass of shit disappear from the lung. And when I show it to them, they say, oh, suddenly the referrals increase in numbers. So this is an aspergilloma. These are the references. We ourselves have published recently our experience with VATS management in 41 cases. This is the paper. So this is the paper, famous paper by Dr. Massard, which is the most quoted paper. So the summary of this is that this has been a very feared kind of a disease. Everybody thought that it has very high morbidity, very high mortality, but our experience is, and now there is more and more evidence in the literature, that surgery is the best option for a fit patient, mind you, fit patient with localized aspergilloma, whether it's a simple aspergilloma where it's just an aspergilloma with normal lung, or a complex aspergilloma which has the surrounding lung also disease. It's a difficult surgery, no doubt. It's possible safely in experienced hands with reasonable outcome. A careful assessment of the risk versus benefit ratio is, however, required for consistently good outcomes. VATS is also now possible. If applicable, it may be safe and efficacious. Simple aspergilloma in particular is a good indication for VATS, and sometimes you may be able to do it in complicated aspergilloma also. However, when you have a bilateral multiple sites aspergilloma or patient has a very poor pulmonary reserve, then cavernostomy, which basically means you open the cavity, remove all the contents and put a muscle flap over the area, or even do a localized myoplasty, a thoracoplasty, these may be the possible options. Lastly, hydatid disease still continues to occur in many parts of the world caused by echinococcus. Dog is the primary host, man is only an accidental host. Patients present with chest pain, cough, expectoration. Sometimes this cyst can rupture into the pleural cavity, forming empyema, or into the bronchus or pneumothorax, or even cause an empyema. This is how it looks. Most of the times we are able to excise it completely. So we just give a cut and the whole cyst pops out of the lung. Sometimes they could be occurring at multiple sites requiring multiple excision. The summary, mainly it's a surgical treatment. However, you should always precede it by giving albendazole so as to sterilize the cyst contents, which reduces the chances of post-op recurrence should intraoperative spillage occur. Principles of excision, most important since it's a benign disease, preservation of lung parenchyma is the most important, and equally important is the fact that you should avoid spillage of cyst contents because that reduces. So surgical approach will depend on intactness of the cyst, number of cysts, size of the cyst, and whether they are unilateral, bilateral, and whether they are associated with destruction of lung parenchyma. If you do have destruction of lung parenchyma, sometimes wedge resection or even lobectomy may have to be resorted to. Thank you very much for your kind attention.
Okay, thank you very much for a very good overview of complex infectious diseases, which are not just restricted to the third world, but are coming to a